Ladies and gentlemen, without further ado, I'll be taking you through a case discussion. And this is the last, before we have a little quiz, this is probably going to be the last of the lecture series today. And this will just take, it's quite a long-winded thing, but I think if you understand the lecture, this will reflect on what the case is all about. Now, right. So we have Mr. X, a 61-year-old man who presents to his general practitioner together with his wife. He's complaining of difficulty achieving an erection for the past 6 months. So the question is, what additional history would you obtain to further assess his condition? So I'll just give you a couple of seconds. Now, we've spoken about this as part of the history taking and assessment. So basically, this patient will be having details on his sexual dysfunction itself, how acute it is, how the duration of sexual dysfunction, the lack of libido, rigidity of erection, the duration of sexual stimulation, the difficulties with ejaculation, orgasm, and also the absence of the morning erection. So all these things will be part of the history taking and his complaints. Now, the next part would be the medical and surgical history, find out whether he suffers from hypertension, diabetes, whether he's obese, whether he has hyperlipidemia, cardiovascular risk, any surgeries in the past, and whether he has metabolic syndrome. Now, the medication he's on is extremely important as well, whether he's on any nitrates, antipsychotics, antihypertensives, and then the psychiatric history about psychological problems, whether he's coping with stress in his workplace, at home, any cognitive factors or trauma involved, does he have any depression or anxiety, and the social history about smoking, alcohol consumption, and also illicit drugs, whether there's any dietary problems, does he do any exercise, any cultural and religious aspect changes. Now, sexual history, of course, we have to talk about the relationship status with the partner, what is the perception of erectile dysfunction, whether there's any multiple partners, any gender dysphoria, what his sexual orientation is, as we discussed, sexual exposure, whether he's experiencing any problems with masturbation, whether he's got pornography consumption, and also does the couple plan for any children? Now, apart from experiencing difficulty achieving an erection, Mr. X also reports being unable to maintain an erection throughout sexual intercourse. So this is gradual in nature with no major life event that happened before. His libido is intact. Sexual stimulation, of course, it takes longer now to achieve an erection. He has successful vaginal penetration on and off, and there's no problem with ejaculation, and there is absent early morning erection. Now, of course, we have done that, and now the patient has these comorbidities for the past 3 years. We've elicited that he actually has diabetes mellitus. He's on metformin, 500 milligrams BD. He's hypertension on metoprolol, a beta blocker, 50 milligrams BD, and he's also on anti-lipid, which is an atorvastatin of 20 milligrams once a day. He smokes 5 cigarettes a day for the last 40 years. It's a total 10-pack year of cigarettes, and he's married, blessed with 2 children. He's an executive who works long hours, 60 hours a week. His presenting symptoms have begun to cause significant stress and tension in the marital relationship. So what are the risk factors for erectile dysfunction in this patient? Very evident, and I'm sure you all know the answer. Now, age, 60 years old. He smokes for the last 40 years, 5 sticks, 10 packs a day. Comorbidities, of course, he has diabetes, mellitus, hypertension, hyperlipidemia. Medication, well, we discussed about beta blockers in ED. He takes metoprolol and some work-related stress. Would you consider involving the patient's partner in management of erectile dysfunction? If yes, what relevant questions would you ask the partner to better understand the couple's relationship dynamics and contributing factors? And if no, what would your reasons be for not involving a partner at this stage? So as you know, it's always good to have the partner involved as well to find out what the dynamics are, and basically to find out exactly what really goes on with his sexual performance and satisfaction. Yeah? So having a partner is actually quite beneficial here. So the patient's wife complains of unsatisfactory sexual intercourse. The view of husband's poor sexual performance. He's got poor erections. He's unable to sustain an erection to completion of the sexual intercourse, and successful vaginal intercourse only occurs or often occasionally. She also claims that her husband is not taking his medication regularly. He's not compliant. He's having a very heavy late night snacks almost every day, and he's not exercising regularly. And eventually, the presenting complaint has always caused a marital tension or disharmony. Now, as per our recommendation, a comprehensive medical, psychosocial, and sexual history should be taken in every patient presenting with ED. A validated questionnaire related to ED is used to assess the sexual function, and this here is the IIEF, okay, the International Index of Erectile Function. A focused physical examination is required, and ED should be done, and this should identify the underlying medical conditions and also the comorbidities, and if there are any genital related disorders. Of course, the labs are very important as well in identifying the risk factors, and also the specific diagnostic tests performed if it is indicated. And patients with ED who have cardiac risk must be referred to the cardiologist. How would you examine this patient? We'll just take a couple of seconds there. Now, we know that a physical examination often focuses on the genitourinary part, and this also will include the prostate, the endocrine system, the vascular system, the neurological system, and blood pressure, heart rate, and BMI is important. So the waist circumference should be measured along with other clinical examination, part of the cardiovascular risk assessment. A physical examination may reveal a penile abnormality if the patient has a Peyronie's disease, which is the curvature of the penis is abnormal, and if there's a pre-malignant or malignant genital lesion, prostate enlargement and signs suggestive of hypogonadism. Example, if the testes are small, or if there's failure to achieve any secondary sexual characteristics. Some have GPs, and also in the clinic kesehatans, we have the oxidometer. The oxidometer basically will be a tool that can tell the size of the testis, and what we know is normal is between 12 and 16 mils, and this is in the form of beads, so it's easy to see, visualize, and relate. So a comprehensive medical physiological examination, focused physical examination here is very important. And this should identify the underlying medical conditions and the comorbidity, especially the genital disorders. So on examination, this gentleman's BMI was 30, and his weight, of course, 85 for his height. His waist circumference 100 centimeters, the blood pressure 130 by 80, pulse rate 60, his genital examination is normal, and all other physical examination unremarkable. What would you do to investigate? So the CV risk assessment, here, of course, we need the glucose level, a fasting level, HbA1c. We'll probably do a lipid profile for him and an ECG, and other related examination for diabetes would include a renal profile and also a urine protein, which is a microscopic examination. So the additional laboratory test that may be considered on a case-to-case basis for hormonal testing is an early morning total testosterone. This is done between either 8 and 11 or 7 and 11, because it's testosterone is an undulating fashion, and it's best taken in the morning. So total PSA results, of course, if the patient has lower urinary tract symptoms in a 60-year-old, probably do a PSA as well. Luteinizing and follicular stimulating hormone to check the axis. in the event of low testosterone levels, and prolactin also for the hypothalamus and hypopituitary axis, okay, in the levels of low testosterone, and a thyroid function test. Now, routine labs should be performed to identify modifiable risk factors in ED. So that's what we do. And his random blood sugar is 11, HbA1c is 7.6. The lipid profile is deranged slightly, and ECG is normal, and other blood investigations are within normal range. So what are the assessment tools that can be used to assess his erectile function here? We have something called an erection hardness score, which is basically present in every, I think most of the urology clinics would have erection hardness score. It comes in two forms. One is, depicting something like the fruits and, cucumber like you see, and another one is more based on touch. So erection hardness score is measured from 0 to 4, where 4 it is normal and full rigidity. Then there's a 5-item questionnaire, as I mentioned, the IIEF-5, which is a modified questionnaire. And when it comes to psychosocial assessment, there are various psychosocial assessments, the Woolley, the PHQ-9, the GAD-2, and GAD-7 for anxiety disorders. So the IIEF has an English version and also a Malay version, and both are available in the guideline. So here we see a validated questionnaire has to be used to assess a sexual function of the patient. So this patient has a moderate confidence rate. He has he has erections with sexual stimulation, and erections are hard enough for penetrations a few times, so it's much less than half. He has how often would he be able to maintain erections after penetration? Also about something less than half, so it gives it a score of 2. And how difficult is it to maintain an erection to completion? Very difficult. That's a score of 2. And when he attempts to have, was it satisfactory to him? He says much less than half. So that's a 2 as well. So he suffers from an IIEF score between 8 and 11, which is a moderate erectile dysfunction. So what is the diagnosis here? And we can see from the assessment, it is moderate. His diabetes mellitus is uncontrolled. He's got organic erectile dysfunction. Now, as per algorithm, we know that patients with symptoms of ED, after the physical laboratory tests and imaging, we do the diagnosis. This gentleman has organic erectile dysfunction. He suffers from moderate erectile dysfunction, score of between 8 and 11. We first focus on lifestyle modification and pharmacotherapy. And of course, what lifestyle modifications would you like to suggest for this patient? Now, of course, we want him to have increased physical activity. Increasing in blood flow is imperative. Diet modification, weight optimization to lower his BMI. He must stop smoking. The stress management must be measured as well and also assessed. Modify the risk factors, of course, like diabetes, hypertension, hyperlipidemia, and all patients here, we recommend, must have lifestyle modifications done first. What are the initial considerations and steps in choosing a PDE5 or a phosphodiesterase 5 inhibitor for this patient? Now, the factors to be considered would include the onset of action, the duration, potential of adverse effects, and adjustments in dose based on the response and tolerance. So we have a few drugs that are available in our country, namely sildenafil, tadalafil, avanafil, and vardanafil. And of course, each one has its own unique characteristics, and you have to tailor it according to the patient. This is quite an extensive slide, isn't it? It's quite busy, but as we know, there are various drugs, and each drug basically has a different way of action, modality of action, and side effects. And we can pick it based on how the patient reacts. Now, in cases where PD5 monotherapy is insufficient, so what are the other options that we can consider? So we know there is some mechanical devices, right? So we have spoken about mechanical devices and also surgical intervention. So what are the different mechanical devices here? We refer them to the urologist first, yeah? So the urologist will talk about extracorporeal shockwave therapy, perhaps vacuum erection devices. And then the last resort, of course, is the penile revascularization and penile prosthesis. So that's also part of our recommendation, as we spoke about earlier. So vacuum erection devices, not new to us, and it shows very good efficacy, and it's definitely recommended in patients as an armamentarium in the treatment of ED. And low intensity shockwave therapy for erectile dysfunction, of course, targets different parts, different aspects of the penis. And also these is done in multiple sessions. And of course, basically the progress is measured after about between 4 and 6 sessions onwards. The penile prosthesis, of course, is the last resort, and there are different types of devices available. There are the three-piece inflatable penile prosthesis, the two-piece inflatable ones, and the malleable ones. So it's either inflatable or hydraulic or a malleable. And this, of course, is done in centers with high volumes in Malaysia. So with that, I thank you for your attention.